Ejaculation frequency, paraurethral, G-spot activity, hormonal response, and fertility in women. A selective review of limited evidence, 2010-2025, by AZLAN ADNAN, MA. Saturday, 20th of December, 2025. Abstract. Female ejaculation and paraurethral fluid expulsion during orgasm remain incompletely characterized phenomena within gynecology, urology, and sexual medicine. This selective review synthesizes peer-reviewed English-language literature published between 2010 and 2025, excluding case reports and opinion pieces, and evaluates epidemiology, biochemical composition, hormonal response, fertility implications, and clinical guidance. Available evidence supports classification as a normal physiological variant without demonstrated disease association, hormonal disruption, or fertility impact. Introduction. Fluid expulsion during female orgasm, commonly labeled female ejaculation, occupies an ambiguous clinical space. Studies are typically small, self-reported, and methodologically heterogeneous, precluding meta-analysis. This review aggregates higher-quality observational, biochemical, imaging, and endocrine studies while explicitly separating established findings from hypothesis. Terminology and definitions. Female ejaculation refers to involuntary fluid expulsion from paraurethral Skene's glands at orgasm, often containing prostate-specific antigen, PSA. Coital incontinence describes stress-related urinary leakage during penetration or orgasm and represents a distinct pathological entity. Mixed presentation, in which both paraurethral secretion and urinary components are detected, has been documented in approximately 25% of cases in urodynamic and imaging studies. Failure to distinguish these phenomena underlies much clinical confusion. Methods and evidence base. This review covers peer-reviewed English-language studies published between 2010 and 2025. Excluded were case reports, expert opinion pieces, and non-systematic reviews. Study heterogeneity in definitions, measurement methods, and outcomes precluded formal meta-analysis. Epidemiology and paraurethral health. No population-level longitudinal cohorts track female ejaculation frequency or disease outcomes. Self-reported surveys consistently indicate episodic fluid expulsion in approximately 40 to 60% of women, with consistent occurrence in 5 to 15%. Retrospective audits conducted between 2015 and 2023 demonstrate no association between reported ejaculation frequency and urinary tract infection rates, pelvic floor dysfunction, or continence disorders. Skene's gland morphology and clinical findings. High-resolution MRI studies suggest benign paraurethral gland hyperplasia in approximately 3 to 5% of imaged women, with symptoms present in a minority. Reported symptoms include discomfort or discharge. Uncontrolled series describes symptomatic relief following manual drainage, masturbation, or intercourse, though causality remains unproven and should be regarded as hypothesis rather than established benefit. Biochemical characteristics of ejaculate. Proteomic and mass spectrometry analyses consistently show fluid composed predominantly of water, with low urea concentration and detectable PSA. Measured pH ranges from approximately 6.8 to 7.2, compatible with sperm survival. While PSA presence supports paraurethral origin, it does not exclude mixed urinary contribution in all cases. Proposed mechanisms. Hypothetical. It has been proposed that periodic paraurethral duct emptying may reduce secretion stasis or cyst formation. This mechanism is biologically plausible but remains untested. No interventional or longitudinal studies confirm a protective or preventive effect. Hormonal responses. Oxytocin and prolactin. Orgasm produces transient neuroendocrine changes. Oxytocin levels rise acutely, typically 2 to 5-fold, and return to baseline within minutes. Prolactin peaks later, usually within 1 to 2 hours, normalizing within several hours. A small single-arm study examining daily orgasm over several weeks demonstrated no shift in baseline endocrine profiles. No evidence supports chronic hormonal disruption from frequent ejaculation. PAF fertility and cervical fluid dynamics. Ovulatory cervical mucus characteristics are governed by cyclical estrogen and progesterone fluctuations. Experimental and observational data show no measurable effect of ejaculation frequency on luteinizing hormone surges, ovulation timing, cervical mucus quality, or sperm motility. Female paraurethral fluid is neutral to slightly alkaline and lacks known spermicidal properties. Clinical guidelines and consensus. Major professional bodies, including RCOG, ACOG, and EAU, issue no recommendations regarding ejaculation frequency in women. Clinical guidance focuses on symptom management, excluding infection, distinguishing incontinence from paraurethral secretion, and providing reassurance where findings are benign. No guideline advises prescribing abstinence or encouraging frequency. Clinical implications. Reassurance is appropriate when fluid is paraurethral and asymptomatic. Investigation is warranted for persistent pain, hematuria, malodor, or suspected infection with ultrasound or MRI of the Skene's glands where indicated. Volume alone should not be pathologized. Behavioral prescriptions regarding ejaculation frequency are unsupported by evidence. Integrated interpretation. Across observational data, frequent or infrequent paraurethral fluid expulsion is best understood as a physiological variant. No credible evidence demonstrates health benefit, disease protection, or harm. Hormonal effects are acute and clinically insignificant. Fertility is unaffected. Bottom line, evidence aligned. Female ejaculation frequency reflects anatomy, arousal, and context rather than medical necessity. No guideline mandates frequency, restriction, or intervention. Comfort, consent, and clarity, not prescription. Choice, not compulsion.